Dr. Williams, Dr. Alves, Dr. Chance, everybody that got me here. Yeah, I'll need a little bit of light to see what's going on. They give the endocrine system some they don't like. Theoretically, it's complicated. Let somebody else stumble their way through it. So I think that's why Bruce had me do this. And I will talk to a group, and there'll be some of you here that know more than I do, some of you that say, geez, I wish you'd given some more advanced stuff, and some of you that said, oh, it was too fast. But it's just like so many other things you do, you just pick a spot and see if you can find some things in here that you can appreciate. A little bit of the endocrine, I don't want to spend too much time on this, is some physiology. That's up to you folks. Oh, and if I say guys, that's generic to review it. But this where it's dependent upon something, and then the end organ, that's kind of an important concept to keep in mind, because we're going to produce diseases, as you know, that link through the pituitary. But there's these other endocrine organs, and they're independent of the pituitary, or at least, I don't know, 90% are independent. I'm not going to spend time with this, and then I talk about it. But it's kind of a big deal. These proteins and peptides, snap your fingers and they're going to change their secretory rate. Versus steroids are taking a week or more to go through the full process. You can stop some release, but the synthesis and so forth, you got to go through nuclear mechanisms. And then you're going to have diseases that are in that organ, and then you're going to have the lesions that are present in non-endocrine organs. And then this is what I like. Hopefully Tony or Bruce said something about integrating ClinPath along with PATH. That's what I like to do, so they don't just stand alone. And this stuff is, I think it's important to lay the groundwork for it. You know, the endocrine system is unique because we've got not just hypo, but we have hyperfunctioning diseases. We don't worry about hyperfunctioning cerebral diseases. We don't worry about hyperfunctioning kidneys. That's lack of function when they're making too much urine and so forth. So that's a unique thing that goes with it. And then I can produce those diseases through primary or through secondary steps. And that's part of the pathogenesis to understand along the way. And then depending what the substance is, the feedback may not be through the pituitary and trophic hormones. It could be through a substance, calcium, glucose, and so forth. So keep that in mind. And then you have all these other mechanisms that come in. All right, here's what's nice about the endocrine. You get this stuff down, you get this thing down, you can explain anything. You may not be right, but you can explain it by going through the endocrine system. So here's hypofunction, here's hyperfunction. I'm going to put the lesion in the end organ, or I'll put it in the feedback loop. And now I can produce hyper and hypo diseases. Know that concept. If you understand it, you don't have to memorize so much. If you don't, then you go through the memorization stuff. So it's going to fail because of agenesis. It's going to fail because of an immune-mediated process, atrophy. These are all the lesions that you're going to teach those vet students at the back of the room. And if they're in the end organ, yeah, it can produce hypofunction. Versus hyper is really easy. That's almost always cancer. If it's secondary, it's stimulated, that's hyperplasia. And for those endocrine systems, it's kind of nice. There's your cancer. And then on the opposite side, the lesion is contralateral atrophy. You can go down here and put the lesion up in the pituitary, and now it's going to be atrophy in that gland because there's no trophic hormone, TSH, ACTH, and so forth. And hyperfunction, too much ACTH, too much TSH. Get that down. And then it gets to be very simple. And then you can add some layers to it. And this is what I mean. This is when it shouldn't be on Facebook. You can BS your way through anything. As you start to add receptor defects, target cell that fail to recognize or overreact. And iatrogenic could be right up there with all the others. Yep. If you add that hormone in there through treatment, then you can produce those diseases and so forth. So take that principle, put it on every endocrine organ. So I'll pick adrenal. And there isn't time to do all the endocrine organs. So you do hypofunction. Let's put it in the end organ. Lymphocytic adrenalitis. Where's my vet students? Give me your last name. Kelsey? Gelton. Dr. Gelton. See that lymphocytic destruction of the adrenal cortex. For the trip to Hawaii, the washer and dryer. Now we're going to change the adrenal gland to the thyroid. Dr. Gelton, what lesion destroys the thyroid gland? Lymphocytic destruction. Same thing. Dr. Jones. There's always a Dr. Jones in the audience. Make it the parathyroid. What destroys the parathyroid? Lymphocytic destruction. Get down the simple stuff and you get to use it over and over. It's a nice little principle. Sometimes it may overlap and there'll be multiple, but most of the time it just hits one. And then obviously that's the name of the disease for the hypoadrenal lack of function. That's going to be 90%. Now I'm going to beat that into the head over the next hour as we go through this. Or you can have the pituitary tumor that destroys corticotropes making ACTH. Now the lesion is going to be atrophy that's in that gland. Then this one is irreversible. This one is reversible if you could get rid of that pituitary tumor. And you can. So here's hyperfunction. Now put a tumor in the adrenal gland. You can do the same thing with the thyroid. Now put a thyroid tumor in the thyroid gland. It's easy when you get down these principles. And the same thing, we got a pituitary tumor now and it stimulates. That is the most common cause of Cushing's disease, pituitary dependent hyperadrenocorticism. And we've got iatrogenic causes. Maybe for the conference tomorrow, there'll be a cause for hypo. A bottle of steroids produces Cushing's. All the ClinPath data, all the clinical signs outside of the endocrine lesion for Cushing's are caused by steroids. It's not caused by the pituitary tumor, but it's the steroids that are producing the pot belly, the liver changes, and so forth. So basics, basics, basics. Pituitary carcinoma, bilateral adrenocortical atrophy. Pituitary adenoma, bilateral adrenocortical hypertrophy and hyperplasia. This one made ACTH. The carcinoma abrogated all the cells that were making ACTH. Piece of cake. That may be my last slide, Bruce. No, I got another one, right. But that is, get that down. I think it's very important. Now, don't you want me to go through all these details? That's physiology, okay? But it does get to be important if you're going to understand pathogenesis. So we're going to go through the pituitary, ACTH, and then we got GFR. Glomerulosa, vesiculata, and reticularis, the different zones, and then the different substances that are produced from each one. That's physiology. You guys have all had it years and years ago, more and more currently, and now you put it in disease situations. So, cartoons, normal situation, that's the #1 cause of hypoadrenocorticism in vet medicine. It's essentially a disease of dogs, but it can be in kitty cats and some of the other species. Those glands are small and they're being destroyed by the lymphocytic lesion. So what's the concentration of ACTH? Sky high, because you understand from physiology, now there's no negative feedback. So the corticotropes keep producing it. Piece of cake. You can do the same thing with thyroid. With calcium, and you just switch the parathyroid as the feedback loop. And then here's secondary causes. So now there's the pituitary cancer, destroys the cells. What's the lesion? Atrophy. What's the clinical significance of knowing that? It can regenerate. You can't fix this one. Lifelong treatment. You can fix this one if you get rid of that. So it's the same thing with iatrogenic. There's the steroids coming in. They're going to cause atrophy on this side because there's no stimulation from ACTH. It's decreased. For the trip to Bethesda, the washer and dryer. So if you wanted to distinguish whether it was primary or secondary, one substance you could measure is endogenous ACTH. It's going to be sky high with this one, and it's going to be decreased with both of these two. Understand the principle, you don't have to memorize. Oh, this is an important one. All three zones get destroyed by this. Versus with the secondary, it's really just the zone of vesiculata. So with this one, we will have electrolyte abnormalities, and in this one, no electrolyte abnormalities because it's just the glucocorticoid part that's gone. And then that's the lesion. All right, white capsule, this band right through here is the cortex. That's all that's left of it. All three zones are destroyed. It's a lymphocytic adrenalitis, and this is all medulla. In theory, you'd have a 1-to-1 ratio, cortex, medulla, cortex on the other side, and I'll show you a picture of that. You can read some of these words that I've already mentioned so that I don't keep repeating them and we move along. That's the adrenal gland in the upper right as you look at it. Who sees an adrenal cell? I don't. They're all lymphocytes and they're all plasma cells because they've attacked that adrenal gland reacting to some antigen that is being produced, so it's an immune-mediated destruction. GFR. All three zones are going to be destroyed by that, so it's both mineralocorticoid and glucocorticoid deficiency. These will have the classical sodium, potassium abnormalities. And then we'll look at some of the clin path that goes with that. But they won't be present in this version. Carcinoma, no endogenous ACTH, and the lesion is atrophy. Call me collect, it's uncommon. Versus the primary lymphocytic, that's common. That's what most of them are going to be. But there are these pure glucocorticoid deficiencies, and at some point I'll have a slide that lists some other ways that you could do that. There's the bottle of Vetilog. There's the bottle of dexamethasone. There's the prednisone. If that's given to them for a prolonged period of time, then you're going to have atrophy. That's not going to produce an Addison's. Why is that? Because they're getting the steroids. It's not going to produce electrolyte abnormalities because zona glomerulosa is spared. So this isn't going to produce the Addisonian crisis until you stop giving the steroids and you do so suddenly. And you don't withdraw it because that's the underlying lesion. That's what I love about path. It gets so easy to teach medicine or so easy to teach clin path. If you can see those lesions that are present and you understand it, then you can predict some of this other patterns. Should make sense. Mineralocorticoid and glucocorticoid deficiency with primary and just glucocorticoid deficiency with secondary. That's an easy way to differentiate these two. Clin path. That must be a typo. Both can be azotemic. Did I make a mistake with that, Sarah? Dr. Cudd? Both are azotemic. Depending on the study, 90 to 95% of Addisonians are azotemic. Oof. So we better go over that. But that's why renal failure and Addison's disease can look so similar. That's it. Is that the shortest tape you ever had, Bruce?
It's the only tape I've ever had.
All right. Now we do details. Ah, shoot. I think that's a pretty photo. It's just normal. But for the vet students, nice to have a couple of vet students so I can say that. If it's an autopsy, get the adrenals out early on before you start nicking vena cavas or vessels. If you're a surgeon, you better be bold. Oh my gosh, wouldn't that be awful to do surgery in that area? One of my buddies, Kyle Matthews, does that. The adrenals can look a little bit different between the species. There's the dog on top and the bovine on the bottom. That tend to be even more yellow in their pattern. And that's what I mean by 1 to 1 to 1. And that is much less sensitive than ClinPath. It's much less sensitive than a microscope. But those are the ratios that you're looking for to get a rough idea. And then there's the immune-mediated one I showed you. It's all medulla in essence. And then here's the lesion. This is a different case, different color. Capsule. That's probably all that's left of the cortex. See that light band? Yellow, lipid, glucocorticoids. Darker, medulla, epinephrine, norepinephrine. This is the lymphocytic lesion. Textbooks will say that the two most common causes are lymphocytic adrenalitis and idiopathic adrenocortical atrophy. Bzzz, no credit. That's a continuum. There isn't idiopathic adrenocortical atrophy. There isn't idiopathic thyroid atrophy. It's lymphocytic thyroiditis, it's lymphocytic adrenalitis. And when the lymphocytes and plasma cells are done, there's only a few residual cells that are left, and it does look like this idiopathic destruction. And don't use the term atrophy because that's not the case. So those are a continuum, and they're a continuum with, what do you call it? Thyroid glands. So what's the concentration of cortisol for the trip to no place? Low. What's the sodium potassium? What's the endogenous ACTH? And that should make sense to you in each one of those. So it's a glucocorticoid and a mineralocorticoid problem. So there's no steroids and there's no mineralocorticoids. So I'm not reabsorbing sodium, and the potassium goes up. Endogenous ACTH is increased. Poof. You're a clinical pathologist. Released. You can do it. Just a close-up of what we just looked at. The plasma cells, lymphocytes, and then here's what's going to be the residual part of the adrenal gland that's left and why they call it idiopathic. Because the footprints that are telling you how the process started may be gone. They're cleared. Oh, I should say this. Tony would know it. Bruce would know it. Oh, my gosh, stop me at any time and say, nah, I don't believe it. Or a question about one of your cases, because I think the more I get from you folks, Tony indicated that, the better I like it, and then it'll wake up everybody else. So don't hesitate to ask some questions. All right, there's adrenocortical necrosis secondary to lysogen. The goal of OPDDD is to destroy zona vesiculata. If you OD them, overdose it, you'll destroy all three zones. So that should skip zona glomerulosa in the treatment of the pituitary-dependent Cushing's. But if you OD them, yeah, you can produce adrenocortical necrosis. And then there's rare causes, infarcts, fungi, maybe the Wednesday slide conference that could come into play with some of these. But those are oddball ones. But they'd still be primary because they're targeting the endocrine gland. Trip to Hawaii, washer and dryer, foal. Yeah. You know, vet medicine is becoming a disease of dogs and cats. But these diseases are still out there. And so there's the medulla. Now the cortex is, quote, looks enlarged. And yet, I call these an Addisonian. That's hemorrhage, that's necrosis, and one of the first things you want to think of every time you see a circle is there's some underlying vascular. So you see a geometric pattern, vasculitis, thrombi, emboli, and this is what you'll see in foals with viremias and septicemias. Here's another one in a foal. Black, you don't want it. That's necrosis, probably fine. Red. Nice to be a double board certified pathologist. Take his arrow and just say red. See how easy it is? How much of this gland is destroyed? I don't know. But your crude thumb rule is just like the kidney. 75% needs to be destroyed to lose function. That's one of your thumb rules that you'll use. These adrenal glands are so fragile at this point, I can't get you a good histologic section to look at. Fold artifacts, the area hemorrhage falls apart, and they'll come out. This is what it would look like with histopath. Zona glomerulosa in tubes. Medulla, I forgot, where's vesiculata and reticularis? So lots of hemorrhage, lots of necrosis, and there may even be discrete areas of necrosis or septicemia, microabscesses. Here's an adrenal gland, and I really don't know the species. Somebody asked me, somebody give me a species, pig. What's the etiology? Herpes. Somebody else give me a species, foal. What's the etiology? Herpes. Somebody else give me a species, mouse. What's the etiology? Got it? When you go to the exam, have one or two tricks and just keep using them. So if it's a species you don't recognize, alligator, I got no idea if they get herpes, but I'm picking herpes, just backing up with all these others. And then you change the name from IBR to pseudo-rabies and so forth. So there's the necrosis. Here it is up close and personal. It was Dr. McEntee told me, the old Dr. McEntee, the deceased Dr. McEntee, to look at the adrenal glands in these abortions for this lesion, that it could be a herpes abortion and the adrenal gland is a desired site, and I don't know the mechanism for it to be there, and so there's your intranuclear inclusions as well. That could have been a foal with a septicemia, bacteremia, and they'll lodge in those same areas as well. So that would be primary. There is a condition called equine adrenocortical insufficiency. That's the oddball stuff for ClinPath people. That's not this lesion. That's a separate one. But they should investigate for this carefully. So inclusions aren't easy to find, but you got FA. Calves, I'd always pick a septicemia first, E. coli, and they're an animal model for the Waterhouse-Friderichsen syndrome. Massive adrenocortical necrosis, and in this case, secondary to E. coli. But you've got FA. I assume it's faster than us with the scopes, but probably not if you know what you're looking at. The problem is it's in a fetus. What's the most common lesion in a fetus? Autolysis. Yeah, you folks get nice slides that get sent to you, but if you're out there in the real world, oh my gosh, rot, autolysis is still a very real event. And the primary. Then we do routine ClinPath. Oh, you got to be kidding me, Meuten. Then we're going to screen for the test. Then we're going to do confirmatory tests. We'll get him out of D.C., back to Virginia. Well, this is Virginia. Back to Carolina. All right, so this is secondary. Have you seen that photo enough? You got it down. Now just change the lesion, the pituitary for one that you've seen, change the steroid, and then that's what you're going to produce. But look, this is minor league. It takes a big tumor to destroy sufficient corticotropes to produce that atrophy. So very often they're large adenomas or they are carcinomas. Therefore, there may be visual defects, pressure on the optic nerve, optic chiasm, and so forth. But zona glomerulosa is spared. So if I probably should have put a slide of the adrenalitis next to it. I think there's a lot more yellow, because there's a lot more cortex that's still left in this one because it's an atrophy that's present. Only about 10% of zona glomerulosa would be responsive to ACTH. Most of it's not. It's going to work through sodium, potassium. So you don't have that feature that's present with the mineralocorticoid deficient. The key thing here, sudden withdrawal. By themselves, by itself, that's not going to do it. But the prolonged period, because of the atrophy, then there's insufficient time. Whoa, 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 I forgot. What do you mean it's not insufficient time? Shouldn't these hormones be boom, 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 boom? Not the steroids. They're going to take a week or more to crank up the receptors to recognize the problem, nuclear receptors to start the synthesis, and then the cytosol to make it. So this is not like parathyroid gland where it's a peptide and you do get immediate feedback. Let's see, who's been to Hawaii? Oh my gosh, I got one of the vet students who's been to Hawaii. I've never been. I'm envious. All right, so Hawaii's off the chart. Trip to New Zealand. Washer and dryer. Huh, how could that, I don't think that looks like an Addison's. This is oftentimes how they look, miserable, unhappy, and might be renal failure. Wait a minute, what's this dog doing in here with alopecia, pot belly, collapsed? That's the dog that's on the bottle of steroids. This patient doesn't look at all Cushingioid. That one, wait a minute, that doesn't look like an Addison's. It looks like a dog with a possible Cushing's because it was on steroids and then sudden withdrawal. All right, memorize the exact clinical signs that you can see with each one of these. Nah, don't do that. But look at this and realize how worthless lethargy is, and it's 90%. I should have this problem. Decreased appetite, weakness, vomiting. There's nothing there to hang your hat on for an adrenal problem. That's why they'll call this the great pretender, because it can mimic other diseases. And in this case, especially because of polyuria and polydipsia, it could mimic renal issues. I forgot, what percent of these dogs have a high urea, nitrogen, and creatinine? 90%. And now they're polyuric and polydipsic? I'm on renal failure like white on rice. That's going to be so much more common than is Addison's. They mimic each other. So you need to be able to differentiate why that would be present. There's zona glomerulosa, very pretty. Zona reticularis, and the vesiculata is essentially gone. Medulla would be down here at the bottom. So there's the histologic lesion. And then your prognosis for this, as I read my own slides, is great. That one can regenerate. How long is it going to take? A while. Can I be more specific? No. I really don't know. How quickly will the bottle of steroids decrease steroid production and increase Dr. Cohen's ALP in the liver? 24 to 48 hours. That's how fast these events can start happening. But remember, that's the decrease part. Bruce always wants new slides. There's the normal, and there's the microcardia associated with Addison's disease. Or it's an overexposed radiograph. Don't ask me about radiology, but small heart would be one of those. There's not a lot to hang your hat on clinically. However, one that you can hang your hat on, if it's primary, is bradycardia. Here's the dog, it presents, and it's in shock. It ought to be tachycardia. And if you got bradycardia, ding, 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 you should think of this disease. The bradycardia is secondary to the increase in potassium. All right, now these are uncommon to rare. This is the atypical primary glucocorticoid deficient, and it's not due to the pituitary lesion. At least that's what they would say. Therefore, there's no sodium potassium. Glomerulose is okay. This could be due to the decrease in ACTH because it's an early case. It could be an early primary case. But they say some of these will go on to develop sodium potassium. Therefore, it makes sense that it's an early case. What we're used to in vet medicine is seeing a disease at one point in time. Make the diagnosis. One set of ClinPath. Make the diagnosis. Oh my gosh, in human medicine, that would not be the case. Serial follow of the patient, serial follow of the ClinPath data. So these can change over time. This is the unusual situation in foals. This is the stuff where I can lose the audience, where you just give too much information. So if you go on with endocrine, there are some oddball diseases that can also be present. Do keep this one in mind. The septicemia and the viremias, the disease exists in cats, but it's uncommon and very similar pathogenesis as in dogs. Dr. Alves said I did some research in Ohio, and this is just outside Columbus, Ohio. Very good. People know I've fibbed. So this is what we like to do, endurance. So that's one of our good horses, Fury, and that's going out in Tevis, out in the High Sierra Nevada type country at Cougar Rock. He looks like a freaking stallion, doesn't he? He's a gelding. And if you can see my wife's face, which you cannot, this is great to have all this on Facebook, Bruce. I'm sure people are really interested in seeing this part of it. She looks as scared as you could imagine. And yet she's a very confident rider, but that's a pretty tough spot. Hey, Stromberg. This is how he likes his steak. Stromberg, if you go to a restaurant with Paul and he orders a steak, that's how he orders it. I want it so rare that a veterinarian and a stethoscope can get that cow up and walking around. Stromberg, you made it to the seminar. I made his day. Oh my gosh. Oh no, we got to do ClinPath. Any of you here have an interest in going on into ClinPath? Because I know if I said, does anybody here like ClinPath, all your hands would go up. So we won't do that. But if you have some interest, the endocrine system is great to go through some of these. ClinPath is pretty worthless for some systems. Lungs, brain. ClinPath is great for some systems. Endocrine, pretty good for the liver. It's incredible for the kidney. So it's not going to cover all the systems. Bones, ClinPath is almost worthless. But for the endocrine, it's really pretty good. So let's take a look at some of the, this is just something I used to tell Dr. Alves and Troutman years and years ago. Go ahead and list the disease. I don't care what disease, but understand the lesion path. What's producing the disease? And then what are the secondary lesions that, you know, you can see clinically with it? And what's the routine lab data that make you think that disease is present? So there's clinical signs, there's lab data, but something's got to go off in your head to say, what are the tests to rule in and rule out my 4 differential diagnoses? And then what is the test that specifically makes my diagnosis? You could do that for every disease. Corynebacterium equi in a horse. ClinPath wouldn't be the help that you would, but culture and so forth. So that's what we're going to do. These are mineralocorticoid signs. Don't memorize it, but do know bradycardia, and that's because of the high potassium. These are the signs that they associate with glucocorticoid. Don't memorize the columns. Is that a lot of words? There's a lot of confusion and overlap in the clinical signs. That's why they'll mimic so many other diseases, and why clinically they're called garbage hounds, or I don't know why he's sick, but I know he's vomiting. I know he may have a little bit of diarrhea. I know it's dehydrated, and I know he's azotemic. I think he got into something. That's the diagnosis. Isn't doing right, and they'll leave it at that. But why would you treat that dog in the real world? Give him some fluids. You're not at the university? Give him some steroids. What did you just do? Oh my gosh, you did a great treatment of Addison's. You fixed the dehydration, and you gave him what he's deficient in, steroids. And they do fine. 2 weeks later, it represents. Same thing. What do? Same thing. Leaves. You hope on one of those repeat trips, the light goes on. Maybe this dog isn't getting in the garbage. Maybe the owner is right. No, he didn't get into anything. And that's what you have for the history for the Addisons. So sodium, potassium, low sodium, high potassium, you got it. How many differentials for low sodium, high potassium? 4 that you ought to know. 10 if you wanted to impress people in Bethesda. But at least 4 that ought to be at the top of your head. So the sodium-potassium ratio is due to that, potassium. 80% will have a low sodium, so that's a contributing factor. But the point I try to make is the reason you can have 10 differential diagnoses, the reason you should have 4 that you know, is because high potassium happens often with other diseases. Renal failure, high potassium. Uroabdomen, high potassium. Diarrhea, high potassium. Therefore, the sodium-potassium ratios in those three that I just mentioned can mimic Addison's disease. So it's really the high potassium that's present in almost 100% of the cases, nothing's 100%, that's responsible for that ratio. Most of them are some degree of volume depletion. That's the cause of the azotemia. That's worth knowing. Oh my gosh, 80 to 100% of the patients are azotemic. Of course you diagnose renal failure. How come they have a high phosphorus? Because they're azotemic. The number one cause of high phosphorus in vet medicine for my career and everybody that sits here for the rest of your careers, decreased GFR, glomerular filtration rate. So every patient that's azotemic usually will have a high phosphorus that accompanies it. Hypercalcemia is kind of interesting. That's present in about a third of the patients, and that's kind of a, not kind of, that is a helpful feature. You have an azotemic patient, and it's got a high calcium. I've got Addison's in front of acute renal failure. Did you hear that, Dr. Chu, Dr. DiBartola? They're so big on ionized calcium. They're a couple buddies from the Ohio State days. I'd have Addison's up there because a third of the patients may have a high calcium. I can explain it to you, and then you'll forget it. There's about 4 mechanisms that go with it, and they shouldn't ever be on a board exam for anatomics. It could be there for ClinPath. I think as a clinical pathologist that helps out with the board exam, they should be deciding when this is appropriate for an anatomic person to know it, and not all the ClinPath is. So the mechanism, nah. If somebody really wants to know, I'll be glad to explain it. Actually, when you've forgotten the pathogenesis, that's usually what you tell the audience. You don't need to know it, but I could go through it. All right, so that's a helpful hint. What the heck? Why'd medullary washouts show up? Bruce is always worried when, something like this happens. I knew Meuten was losing it, and sure enough, right there in the conference, it came up. Huh. Medullary washout. What the heck? Huh. See how easy it is to be a professor? Huh. That sodium-potassium ratio is less than a number. I really don't care what number you pick. You can find 27, 25, 23 in the literature. Big deal. It's not 40 to 1, okay? When it's really low, oh my gosh, that's almost diagnostic, but not quite. Diseases that are pathognomonic are just about gone. That's not present in secondary. That's in the primaries. Anemia. Every time you have an endocrine disease and the patient is anemic, just choose in the multiple choice answer, lack of stimulus to stem cells. Lack of stimulus to BFUs, CFUs. And that's what the steroids can do. They'll stimulate some erythroid production. Therefore, if what I just told you is true, what would be a ClinPath abnormality in some patients with Cushing's? Increased PCV. They'll have erythrocytosis and even nucleated red blood cells that may be in circulation. Yeah, not in a lot of them, but some. Very often, the anemia is not present on the first time you see the patient. Pourquoi to the French-speaking military people? Because of concurrent dehydration. Remember, he was hypovolemic and azotemic because of that. If he's hypovolemic, dehydrated, it'll raise the PCV. You come along and give him those fluids, and then you see the anemia. And it's usually just a mild anemia that's present. It does stimulate the erythroid stem cells. And then you should know some of the classic stuff, right? Steroids stimulate a lymphocytosis, eosinophilia. Steroids cause lymphopenia and eosinopenia. Therefore, if there's no steroids, the opposite could be present. The most common leukogram abnormality in vet medicine is a stress leukogram. Know that one, especially if we're going to go to the boards. Equal to that would be a stress leukogram superimposed on some inflammation. So if there is not a stress leukogram is high newts, lymphopenia, and eosinopenia, and the patient is sick, that's a hint that it could be Addison's. Because just the opposite would happen that you'd expect to see with steroids. So it's significant that there's no stress leukogram that's present in one of these patients. Oh, this must be another mix-up, Bruce. We got azotemia in here. Huh. Every patient that's azotemic, this is what I say. Get urine-specific gravity. That's how you sort out the difference. And if that urine is dilute, it's not concentrated, in a patient that's azotemic, that's renal until proven otherwise. If the patient is dehydrated, what should the urine-specific gravity be? Concentrated. Notice I'm not giving you numbers, 1024, 1034. Just have a ballpark for what it should be. The patient's dehydrated, it's azotemic, and you got dilute urine, ding, 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 ding. Tomorrow's conference. That's renal failure until proven otherwise. Got it? This is pre-renal. Those are the things you can look at. There's only one cause for increased albumin in vet medicine. Dehydration. That's it. If I see the albumin's increased, it's dehydration. Anybody here heard of bisalbuminemia? That's the only other cause. It's in humans and it's in chickens. If you ever give your own seminar, always have a piece of information that's totally worthless, but nobody else in the audience knows it. So forget the bisalbumin. But the practical one is albumin's increased. That's dehydration, no doubts. Then you decide if it's acute or chronic. This isn't a renal lecture. Whoa, whoa, whoa. What's this medullary washout coming up again? Medullary washout, countercurrent multiplier system. Yeah, somebody told me that years ago, months ago, I don't know. There's two diseases. Now's when I wish I could stand up, Bruce. There's two diseases where this is important. Addison's. I didn't lose it. And colon, shunts. Huh. So that countercurrent multiplier system is made up of sodium. And it's made up of urea nitrogen. Shunt dogs, colon, have decreased urea nitrogen because the liver cells are not making urea. And they can have medullary washout. That means a liver patient, chronic liver failure, could have polyuria, polydipsia because of medullary washout. There's not enough urea nitrogen in the medullary interstitium to suck the water back out. Same thing with Addison's. If it's primary, the sodium is low, and therefore there's not enough sodium in the medullary interstitium, and you lose the countercurrent multiplier system. Is the audience sitting down? 95% of these patients are azotemic, and now I'm telling you, they could be polyuric, polydipsic, and dilute urine. Bzzz. Boy, that's why you mix it up with renal failure. Got it? Azotemia, dilute urine. That's renal failure in my mind until proven otherwise. Exception, Addison's. So look how easy it is to mix up Addison's and renal failure. All right, but if you got that ratio, it's below some magic number, Addison's. Uroabdomen, I'd love to give you a lecture on uroabdomen. I got great diagrams to go through the pathogenesis, but Bruce said, no, don't you dare. And then there's renal failure. This is an easy one, GI disease. Whether if it's calves, I'm on to E. coli. If it's a dog, whipworms and salmonella. And then you got an artifact. I think anatomics should know the first three when they go to the board exam. And then the ClinPath people got to know these others that are in there as well, okay? Forget it. Yeah, there's going to be other causes. Pomeranian, Lhasa Apso. Dogs have people have high potassium in the red cells. Therefore, with hemolysis in people, you see a high potassium. Dogs have low potassium in the red cell. So you don't see that. Bzz, unless it's an Akita and some other breeds. Trivia, sheep, young horses have high potassium in the red cells. Isn't ClinPath great, Williams? So these particular breeds and then some of these others are oddballs, and they'll have potassium-rich cells. So if there's hemolysis, they'll have high potassium. If the clinical veterinarian lets the red blood cells sit on the serum too long, that potassium will leach out and it'll raise it. And you'll end up with ratios that look just like Addison's. Artifact. All anatomics should know the word artifact. We see it all the time in histologic sections, and that is the anatomic's most common explanation for the lab data. I don't know, it must be an artifact. So sometimes it actually does happen, and that would be one. I don't know. What the heck? Plasma cortisol, before you give it ACTH and post-ACTH. So the diagnostic test to confirm Addison's is an ACTH stimulation test. Is that below 25-1? Wow, that's almost at the level of it's got to be Addison's. Look at this dog, 14-1. That's got to be Addison's. Here's the values of cortisol, 60. That's off the chart. The only one here that I would think could be Addison's might be that patient right there, because it's less than 2. That's just something that you can memorize. Oh, here's one that's less than 1. But then post-ACTH, that's a 20-fold increase. Huh. That's Dr. DiBartola's work. Whipworms, some salmonellas, that'll cause a pseudo-Addisonian, or what looks like an Addison's package. If this was calves, that's E. coli diarrhea. If that's foals, it's pick your diarrhea. Because the patient is acidotic, that raises potassium, a potassium-hydrogen exchange to buffer the acidosis, and they'll have this sort of ratio. So Akitas, whipworms, E. coli can look like it. And I've already mentioned that hypercalcemia, especially with azotemia, could hint. Look, we got to speed things up. Can't be here all day. What do you want to do to confirm he's got Addison's? What's your test to rule in and rule out equine infectious anemia? What's your test to rule in and rule out lymphoma? PAR, cytology. What's your test to rule in, rule out any disease? There's a test. That's usually ClinPath, but doesn't have to be. It could be a biopsy. So the screening test, you either measure basal cortisol, which we always said, no, you can't measure basal concentration of hormones. You need to do a provocative test, suppression or stimulatory, to be sure. And an ACTH stim is, in fact, the gold standard. So if you had to go before the hospital board, that would be the test they'd want to make sure you did. It costs $300. Our veterinary practice is in Boone, North Carolina. Did you hear how you pronounce it? Boone. B-U-N-N. Boone. Nobody's paying $300 for an ACTH stim. Now, that's just to get your attention. People would pay that. So there's more than one way to castrate a cat, and they all hurt. Basal cortisol, if it's really low and you have those sodium-potassium abnormalities, that's good enough. And the literature would say it's good enough. Basal cortisol is low with both primary and secondary. And then they're going to give you some number, and you're measuring the glucocorticoid, not the aldosterone, and that the number they'll give you is if it's less than 1. If it's less than 2, it's very suggestive. But if it's less than 1, that's great. Regardless, that's to rule it in. You can rule out Addison's if the cortisol is increased. Both primary and secondary, it's supposed to be low. So that's not an issue unless you were seeing a real early disease. And we're not going to deal with exceptions here. So it's an excellent test to rule it out. ClinPath is terrific. It depends how you use it. Some tests you need to use it to rule it out the disease rather than the way we're trained to rule in the disease. Save money and time, you can use basal cortisol. If the value is really low, you can rule it in, and you have classic electrolyte abnormalities. And you can definitely use it to rule it out. And then this is the gold standard, ACTH stim. So you take a value at some number, 3, 2, it's got to double. If you've got adrenal cortex, zona vesiculatus cells that can make the stuff. And then this is what your Addison should be, flatline, a lot like Dr. Williams in my seminars, flatline. Ho, ho. That's the principle. You do that test in an hour to 2 hours. ClinPath people need to know something about the methodology. Low dose, high dose, you guys don't. Get the principle down. And that is the gold standard. What did we just rule in? Addison's. Which one is it? Primary or secondary? My favorite answer. I don't know. All that I know is the cortex didn't respond to ACTH. That can be primary or it can be secondary. Let's go to Las Vegas. Where are you putting all your chips? Primary. That's 90% of the cases. You know, we work real hard to diagnose a pure glucocorticoid deficiency. So if we wanted to distinguish those two, and you went back to my first slide, my first slides are the most important, then you don't need all the others. Endogenous ACTH. What's the ACTH coming out of the pituitary gland? If there's a pituitary tumor and it's decreasing the corticotropes, then I want my endogenous ACTH to be rock bottom. If I give a bottle of steroids and I suppress ACTH, I want my endogenous ACTH coming out of the pituitary, rock bottom. Versus if it's primary, there's no negative feedback, therefore ACTH coming out of the pituitary should be sky high. That's a great way to do it. These are reference intervals that would be present over here. That test is expensive. The blood can't touch glass. It needs to get to the lab quickly, or you can add an inhibitor, aproctonine, or however you pronounce it, and then that'll stop the degradation of the ACTH in vitro. Does that make sense? Piece of cake? How come there's only 3 dots here and there's 50 dots here? Because 90% of the cases are primary, and that's really an uncommon cause. Everybody on Facebook right now thinks there was a malfunction. Versus when you give an lecture, you got to pause at some point. Give a little breathing time. You really need to spend $200 of their money to differentiate which one it is? If it's primary, how many zones were destroyed? You're a pathologist, all 3. Bingo. So there's sodium, potassium abnormalities. Don't hesitate as an anatomic pathologist to say, send me the lab data so that I can look at it. It can help you interpret lesions. And in this case, it would greatly help me. So if I wanted to distinguish which one it was, you just give me the sodium potassium ratio and I can probably handle it. Give me a basal cortisol combined with that, I'll handle 95+% of the cases. Can I handle 100%? No, there'll always be exceptions. There will always be early cases. There's always gray zone cases. How many times have you struggled with a tumor, what its name is? Because it's gray zone, it's not fully differentiated. Sometimes we struggle with, is this inflammation or is this cancer? Those are the real gray zone cases. And you've seen some of those. Nodular fasciitis is a good example of an anatomic lesion where it's tough to sort out which one it was. Those are our differentials. We did it. What you want to know now is, what is the test I use to rule in and rule out Addison's? For the trip to no place, since we've just done it, those are your 2 tests. If you think it's uroabdomen, what's the test to rule in and rule out uroabdomen? I measured creatinine concurrently in the belly, abdominal cavity, and the serum. If urine is leaking into the abdominal cavity, the creatinine must be sky high, at least 2-fold, 5-fold greater than the serum, because I've got urine in the abdominal cavity, and urine is rich in urea. If the patient's got renal failure, what's the test to rule it in and rule it out? Endogenous creatinine clearance, exogenous creatinine clearance. Bzz, nobody does that. Just give them some fluids and see if they get better. What's all the data say? What's the urine? If it's whipworm disease for the trip to no place, what's the diagnostic test? A fecal flotation. You know, you got Trichuris vulpus there or not. And then you do the same thing with all these other, and that's what ClinPath is, numbers. And if you want a lecture on ClinPath, I could give it to you. They're just numbers, and you draw your arrows up or down, and then you compare it to the reference interval. And it's easy. For the next 2 hours, I'll talk about the disease in cats. It's rare, and it really resembles the disease in dogs. Just leave it at that. Otherwise, I think it's just information overload. The dog's not happy. You agree? He's a young dog. Runs loose. Always ask the owner when they tell you no, the dog doesn't run loose. Say, how high is your fence? Oh, we don't have a fence. The dog runs loose. You'll get lots of people don't believe, oh, no, he would never leave the yard. All right, so I don't know what the PCV should be, so you just go look at the reference interval. They have to give it to you, whether it's an exam or real life. So you draw an arrow up. You pick a name, polycythemia. Then you know causes, polycythemia vera. Now that's in Bethesda, FIP, rare. Dehydration, right? That's your first thought, anyways, that you go through. I don't know what urea nitrogen should be because, Sarah, where'd those values come from? Like Germany or someplace? Yeah, I don't know. And you're going to see a value tomorrow, like maybe 400. And all what you do is go look over here. Poof. So 88, you draw your arrow up. Creatinine's up. Pick a name. Azotemia. Pick 3 causes. Pre-renal, renal, and post-renal. And I cannot tell you which 3 it is by looking at urea nitrogen and creatinine. I can tell if I look at specific gravity. Normal specific gravity is 1.000 to 1.080. Whew, that seems like it's worthless. And it kind of is, but you have expected ranges that it should be. That's close to that magic number of isostenuria. You know, somewhere around 1014-ish. Don't memorize exact numbers, okay? Azotemia, inability to concentrate with evidence of dehydration. Renal failure, every time. Got it? Sodium, low. What do the kidneys do? Save sodium. Potassium, high. What do the kidneys do? Dump it. Kidneys save chloride. That all fits with chronic renal failure. May not be too severe because of this. Draw arrows on your exams. Draw arrows in real life. Those are your differentials. What's your test to rule in and rule out renal failure? You know, if you thought it was ethylene glycol, there's a test. If you thought it was leptospirosis, there's a test. Look, pathology is medicine. My diagnosis is renal failure. I think it's chronic. My etiologies for chronic renal failure are familial renal dysplasia, chronic end-stage kidneys. What's the test to rule in and rule out each one? 24 hours after they gave him fluids because he's dehydrated, look what his PCV is. 24 hours after they gave him fluids, look what his urea nitrogen and his creatinine are. Look what all his electrolytes are. You cannot fix renal failure overnight. So if my primary diagnosis was renal failure and fluids fixed him, I'm wrong. It was pre-renal azotemia. That was one of our differentials over here. We knew it wasn't post-renal because you got urine. There's only two causes of post-renal. It's obstructed or it ruptured. You don't get urine. And there's an exception. So when you fix renal failure overnight, it wasn't renal failure. Therefore, one of your best next differentials for this would be Addison's. What's your test to rule it in and rule it out? Here's what's so easy about medicine, ClinPath, path. Once you get it down, you just keep doing it over and over and over. I can't make up two new tests. ACTH stim and basal cortisol. Uroabdomen. Creatinine in the belly, creatinine in the serum. And you just do it over and over and over. Got it? For the trip to end this seminar, why can't he concentrate his urine? As a vet student, what did you hate to hear? Countercurrent multiplier system. So the reason he can't concentrate his urine, medullary washout because of low sodium. When Cullen gets here, is it Friday? And the same audience is going to be here? You got to make sure you ask them. Any of these patients ever have polyuria and polydipsia? And what's the mechanism? Make sure Cullen gets this so he prepares himself for it. John would know the answer. But for those diseases, it can happen. That's my son, Travis, with a kitten. That's my son, Travis, with a binturon. He's now a pathologist. I think he mastered euthanasia a long time ago. Maybe this won't make it on the internet. We race endurance horses. They got to be tough. They're going to go 100 miles. They got to be mean.
Take 5.
No way. Now we do cushions. Yeah, no, wouldn't it be good to check out urine-specific gravity? Take a little break? I would. Just is that clock right? Yeah. So be back here before, quarter after? Yeah, and then we'll go through cushions. And if you have questions, come up now, and won't point you out, but I'll bring it back into the talk.
Oh. It's like the old days. It's like the old days. I hope so.
For those of you who are listening, we will come back in 8 minutes and cover Cushing's disease. And then I'll download it tonight and upload it to YouTube. I talked to her and sent that message to the I talked to the page together, so upload this stuff together. Yeah, but I keep a copy of all of them. My age drive. Yeah, the server from somewhere. This works fine. See the gray down. Scroll, nobody's done, so we'll just say.
Oh, you can run this.
Don't worry.
usually do
Oh,
that.
If you're buying tablets, you'd be okay. But anything that involves flow, the reason some people say, oh, no, you're flat, we're just worried about
I took my primary care job and I'm going to be starting residency in pathology in Wisconsin. But I practiced around here, so I came and hung out and familiarized myself with histopath again.
Kids are like good medicine.
Yeah.
When you know the medicine stuff, they get easier. Good, cool.
Thank
Yeah.
you.
Very welcome.
Hi.
Talia.
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 Yeah. I have a quick question.
Yeah.
Skeleton.
Good names, huh?
Quick question about the sodium potassium
Yeah.
ratio. If you patients on diuretics, you can use things.
Yeah, anytime not anytime, you have certain treatments in there, and that don't have to be good for the patient. So you have specific ones with diuretics,
Specifically about sterilizing potassium sparing, I don't know if it would worsen your balance or.
and then you're talking about using that in and out of sodium, or just?
Yeah. I guess.
Yeah. You wouldn't really want to be careful. And, yeah, it could be one of those drugs. So,
In terms of what am I doing?
yeah.
Yeah, I'm over there. I'm going into.
So you're.
Yeah. Yeah.
Where'd you go to this?
Yeah. And then the follows that.
The one diet.
He's visited a couple times and very confident. They don't teach us anymore. Yeah. It's now Durham, and
Yeah, as long as I'm angry, I'm going to college.
yeah, I know, and they very recently got.
Yeah. So the more you know, either one. I did it.
Every time you have a muscle one, you're like, my name's
Look, you're my primary care. Give me.
Those people look.
That's most of them leave. Yeah, that makes sense.
It does.
Take his residency.
No, we have three. Just one. I downside 2 hours ago. Just to make sure.
This is right now.
Because you're on so long. I do both. Okay, I just saw you walking up around. Can you imagine how remarkable it is?
Well, I'll wait till there's enough people in here, and then we'll get started. I'm not sure why that slides up there. Yeah. Go ahead and start, Bruce. Yep. So now we do hyperfunction of the adrenal glands, and it's exactly the same except it's opposite. In other words, is it pituitary dependent or is it in the adrenal gland? And here's the part that's opposite. When it was hypofunction, 90% were in the adrenal gland. Now 90% are in the pituitary. And if it's a kitty cat, some people don't like me to say that. If it's a cat or if it's a horse, I mean, they're essentially 100% pituitary dependent. So if you know where the lesion is, you can predict how it's going to behave in the other species. And then only about 10% or so are in the adrenal gland. And who cares about other oddball species? And Bruce would have to be the one to explain how these other hormones get involved. I state that the adrenal tumor is about 50-50 benign and aggressive. I don't know if there is a good study out there that really gives that to you. And then you can have iatrogenic. So those are the number one, spontaneous. This might be the number one cause overall, too much steroids. All of the ClinPath data, all of the non-endocrine lesions are due to glucocorticoids, the steroids, not the pituitary lesion, not quite the adrenal lesion. So that's important to know. And then here's the cartoon that does normal, the pictogram that does the adrenal tumor. Why is that thing so tiny? Contralateral atrophy. There will even be ipsilateral atrophy in the little bit of the adrenal gland that remains. And then that's only 10%. And then this is 90 to 100% of the cases, depending on the species. And notice how that pituitary is the same size as that one, and that one, and that one, because the lesion most frequently is a microadenoma. It's small. That is not going to kill the dog. That makes too much ACTH, and the increased steroids are what will kill the dog, make them susceptible to infections and so forth. But that's really not a big deal in itself. That's why you can tell an owner, yeah, give me $2,000 and I'll treat the dog for Cushing's, but I'm going to leave the brain tumor in his head because it's a microadenoma, or it's just a nodule of hyperplasia that's present. And then the nice thing about vet medicine, you do get to forget ectopic mechanisms. They've been described, but they're really rare, okay? In human medicine, this is fairly common because this ectopic source of ACTH comes from oat cell, small round cell tumor in the lungs. How many of those have you ever seen in a dog? Bzz, they're really rare. So, and that may be the reason we don't see the ectopic mechanisms. So from a practical standpoint, forget these. If you wanted to criticize me, you could say, oh, yeah, there are the rare cases that have been described, but it's going to be those others. This photograph is one of the most common in vet medicine from Dr. Capon, mentor. And then this one's pretty good size, but it makes it nice for teaching. It could just be a little nodule that's present, and you might only find it on sagittal section. But the morphologic diagnosis for me would be pituitary adenoma, pars distalis. Corticotropes are probably responsible for it. And bilateral adrenocortical hypertrophy. I don't care if you say hyperplasia or not, but they're big. Look at how the medulla is almost not visible. Trip to Hawaii, wash and dry, or going back overseas. Diagnosis? Pretty good size. Hard to know from here, you know, adrenal adenoma, maybe it's a carcinoma. That's why they invent microscopes, as Dr. King said. And then what's that producing? Trick question. What's it producing? Nothing. One. Bingo. Just because there's an adrenal tumor doesn't mean it produced anything. So I would say that's non-functional because there is not ipsilateral atrophy of the adrenal cortex. Small dog, small adrenals, that's the adenoma that completely fills the adrenal gland. Now I'm going to say this one is functional. There's the medulla, the red stuff, epinephrine, norepinephrine, lots of blood vessels, that neuroendocrine pattern that you see histologically. And then here's all that's left of the cortex, that thin little rim. So there's contralateral atrophy. Endocrine tumors can be small. They may be little, but they be mighty. So they can be small, but secrete enough hormone to cause disease and atrophy on the other side. Good? Good old anatomic path. Understand that, and then it gets pretty easy to understand other events that go along with it. So one of my friends, so to speak, said, Meuten, you're not so good with your ClinPath tests to differentiate pituitary dependent from adrenal dependent. I'm going to use imaging. I got kind of intimidated because our tests are not perfect and they get a little complicated, but my other friends that do imaging say it kind of depends on the size of the tumor. And the tumors in the adrenal gland are only 10% of the cases. So what you're trying to recognize with imaging would be hypertrophy and hyperplasia. And that gets even trickier. So, phew, I still have a job being a clinical pathologist. Lesions. One, nodular adrenal cortical hyperplasia, dogs and horses, non-functional, no great shakes. Ultrasonographer needs to know, somebody in medicine needs to know, yeah, you can have little nodules on the surface of the cortex, no big deal. Real common lesion. The trip, well, I can no longer say for the trip to Ames, Iowa. Morphologic diagnosis. You always want to be first. I'll go first. Pheochromo. It's white, you know? It should be white or pink. But that's, better not pick that area. I'll pick this area. That's yellow. Now I'll pick a cortical adenoma. And that would be nodular cortical hyperplasia. Yeah, so sometimes you can have multiple ones. That's really for the anatomics. You got that slide, Bruce?
Got it.
He's got them all. I think that's why he brings people in. Bring their baseball cards and I already got it. I don't care. The first time I saw this, I said, oh my gosh, this has got to be a disease. No great shakes. Melanosis in the meninges, melanosis in the adrenal glands, melanosis in Suffolk sheep, Angus cattle. It can be incredible. But when I saw that on the natural surface and then on the cut surface, but no great shakes. Huh. Big deal. One side, the other side. I think predicting whether that's a pheochromocytoma versus adrenocortical can be tricky. From gross, if it's in the vena cava, I favor pheochromo, but it could be a adrenomedullary. The more yellow it is, the more I favor cortical. And then Dr. King, that's why they invent microscopes, you know, or cytology. Get a slide of it to be able to tell. So they called that one a carcinoma and then contralateral atrophy. This I kind of like, and that's the tumor. And hopefully, yeah, that looks like lipid-filled cells. So that's the adrenal cortex. And this is Extramedullary hematopoiesis. When I can find extramedullary hematopoiesis in one of these tumors, I feel very comfortable it's adrenocorticoid. And I guess it's, again, the steroids stimulating some of those events, as well as the adrenal gland along with the liver was the site of hematopoiesis in the fetus. And as you know, dedifferentiation, cells can return to functions in the embryo as well as produce other substances. But isn't that something? Megakaryocytes, iron, there's the tumor that's present over here, metarubricites, and then I couldn't tell you which some of these other larger cells are. You pick the ones you can't identify. So that was both erythroid as well as myeloid, and even a little mitotic figure that's present as well. Extramedullary hematopoiesis favor adrenocortical. What are the non-adrenal lesions? So for this audience, lesions. For those of you that want to go into medicine, clinical signs that you associate with Cushing's disease. Name 10. Pot belly, so it could be either Bruce Williams or Don Meuten. Thin hair coat, could be either Bruce Williams or Don Meuten. Gynecomastia, neither one of us. Prominent cutaneous blood vessels. They got a big abdomen because of muscle atrophy. They got a big abdomen because of hepatomegaly. Isn't that nice? Medicine is pathology, and pathology is medicine, and you can bring all these together. Calcinosis cutis is one of those lesions they talk about as pathognomonic, much like myxedema, pathognomonic for hypothyroidism. It may be pathognomonic, but it's only present in 10% of the cases. Cystitis, bronchopneumonia, secondary to steroids, increased susceptibility to infection, decreased ability to fight, well, decreased inflammatory response, which is one of the advantages of using the steroids, and then the disadvantage, secondary infections. And the hepatic lesion is glycogen, not lipid. So when Dr. Cohen gets here, he'll tell you when he sees glycogen or suspects it's glycogen, steroids, exogenous or endogenous. Versus if it's lipid, then you start to think of diabetes mellitus or other causes of the fat that's present. If both are present, can be concurrent, DM and Cushing's, because they'll be present in about 1/3 of the cases will have the other disease concurrently. An embarrassed naked poodle. Not very itchy, not hyperemic. So what's the routine lab data that makes me think that poodle has Cushing's? Then what are the specific tests that I can run to prove it? And I think at the bottom it emphasizes that all the lesions that you're going to see in ClinPath are due to the steroids. All right, there's a list, and that's what you got. Folks are very good at memorizing, and I wouldn't do too much of that. But the most common leukogram abnormality in vet medicine, stress, or stress superimposed with inflammation. So just know that that should be eosinopenia, lymphopenia, and a mild, moderate neutrophilia. That's a stress leukogram, but it doesn't help diagnose Cushing's by any means at all. Increased packed cell volume, nucleated red blood cells that are inappropriate. It doesn't have a regenerative response. I think of things that disrupt the microvasculature, lead toxicity, hemangiosarcoma, Cushing's. If you have nucleated RBCs and regeneration, and they are in appropriate numbers, that could be the explanation. Inappropriate. If I was to go over and touch Dr. Williams right now, that reaction would be inappropriate. Inappropriate nucleated RBCs in circulation without regeneration, yeah, think of those 3 diseases. Alk-Phos is a huge help. And 95% of the dogs have an increase in Alk-Phos. 95% of sick dogs have, that's an exaggeration. 80% of sick dogs have an increase in Alk-Phos. Why? Sick, stressed. What's the most common leukogram in vet medicine? Stress. What's the stress going to do to Alk-Phos? increase it. How long does it take to increase if you give steroids? 24 hours, 48 hours. So although they'll have an increase in alk phos, so don't a whole bunch of other diseases. However, magnitude matters. That's politically correct, Bruce. So magnitude matters. The key thing is that it's markedly increased. So 95% of the dogs have an increase because it could be mild, and that doesn't help me. But if I have a marked increase in alkaline phosphatase, Cushing's, biliary carcinoma, and cholestasis are my three most likely differentials. So a markedly increased alk phos, that does help me think of Cushing's. Along with it, biliary stasis, because remember, alk phos is a productive enzyme. It's being synthesized. It doesn't leak out. So things that would stimulate that biliary tree to produce it. So if it's markedly increased, I like it. For the trip to no place, for the trip to South America, and the audience that's sitting there, how could I then use alk phos to help me decide if it's got Cushing's or it doesn't? If alk phos is not increased, it's very unlikely to be Cushing's. 85 to 95% of dogs with Cushing's have an increase. If you think it might have Cushing's and alk phos is not increased, it probably doesn't have the disease. Now, you need to do more than that. ClinPath is not always about this abnormality suggests this disease. You can also use it to rule out diseases, either by the presence or the absence of the substance. You gotta laugh at that photo. There's the dachshund disguised as a seal. I don't know what he's got. He's fat. And that could be nutrition. Could be diabetes mellitus. It could be hypothyroidism. And it could be Cushing's. Can you imagine hitting the blood vessel, a vein on this dog? Wow. Okay, this dog was overfed. So this is not a Cushing's. And the reason I bring it is he looks as sad. Oh, that's the tragic face appearance of a hypothyroid dog. That dog was owned by a nutritionist on the campus of North Carolina State University. I mean, you can't make this stuff up. How could a nutritionist let their dog look like that? But it's fun to show it as, you know, this could be Cushing's. Now, what test can we do to rule in and rule out that disease? This is always the seminar you want right before you go out for the end of the day. Oh my God, he's going to do screening tests and confirmatory tests for Cushing. So these are the screening tests. I could do an ACTH stim. This is the one everybody knows, low dose Dexy. And this is the one that's practical, urine creatinine cortisol ratio. Those are screening. They do not tell you which type of Cushing's he has, but you use those to rule in and rule out the disease could be present. Practicing veterinarians do not like that. It costs $300. Practicing veterinarians don't like it because not 100% of Cushing's have an abnormality. Meuten likes it because only 15% are false positives. This is the test I recommend if somebody calls up and they consult and says, you know, I don't really know he's got Cushing's, but he might. This test, and this is the one I tell them to do first, urine creatinine cortisol. Why? $20, maybe $40. Why? Owner brings the urine sample from home. If that's not increased, he doesn't have Cushing's. So that's a great, simple test, not to rule it in, but to rule it out. This is a good test because the fewest false positives. You do not want to make a false positive diagnosis for Cushing's because you're going to put him on Lysidren and wipe out his adrenal glands. Because you're going to open up the abdomen and look for an adrenal tumor. You don't want false positives. You can have false positive diagnosis for hypothyroidism. Why? You're going to give him a bottle of levothyroid. Give him some steroids. There's almost no side effects. Barry Bonds likes steroids. A lot of athletes like steroids. And nothing wrong with levothyroid. Trust me, there's a lot of dogs walking around on levothyroid, and they do not have hypothyroidism. But the symptoms went away. And that's because, if I gave you the thyroid lecture, the euthyroid 6 syndrome is so common. But this disease, I don't want to have false positives. So I like ACTH stim for that reason. Because ruling it in, and it's not present, that's got terrible consequences for Cushing's disease. Now, here's one of the reasons people don't like it. Only 40%, 60% have increased values, and 40% of dogs with an adrenal tumor would be in the normal range. Huh. And I say that's not too bad. That's okay. Why? Because only 10% of the dogs with Cushing's have an adrenal tumor. So even though I'm missing some dogs with the adrenal tumor, I know that's a rare cause. Not rare, but an infrequent cause of Cushing's. So that's not too bad. Low-dose dexamethasone suppression, ding, ding, ding. That's the test all the veterinarians like in practice. How come? 95% of the dogs with Cushing's have abnormal results. 100% of the dogs with the adrenal tumor have abnormal results. Isn't that great? That's what you want. These tests, if you just hear the name, low-dose dexamethasone suppression. So a normal dog should suppress. ACTH stimulation. A normal dog should stim. So the name tells it. Well, that seems pretty darn good. What's bad? Oh my goodness. 60% false positive test at 8 hours. 1/3 false positive at 4 hours. See how easy it is to be a professor? You just got to know how to whistle or say, huh? What do these dogs have? I forgot. You guys got to help me. What's the most common stress leukogram? I mean, what's the most common leukogram abnormality in vet medicine? Stress. They got too much steroids. So what could happen with the low-dose dexamethasone suppression? Bingo. They fail to suppress. You got a tremendously high false positive rate. They don't have Cushing's. They're just sick, stressed dogs with diabetes mellitus, hypothyroidism, renal failure, garbage hound. You go ahead and name the disease. They'll have, quote, a low-dose dexamethasone suppression. They'll fail to suppress because of the steroids that they have floating around in their circulation. So you don't want to put these dogs on Lysodren or do abdominal surgery just because they had a low-dose dexamethasone suppression that looked like it. I want you to retain that thought, okay? And then I'm going to come back to it. Well, I'm going to come to it right away. If this is what your patient looks like, it's a poster card perfect dog for Cushing's, go ahead and do the low-dose Dexy. That's okay. Got it? It's got nucleated RBCs. It's got a stress leukogram. It's got a 5,000 alk phos, and it looks like that. Poof. I'm not, yeah, I'd pick low-dose dexamethasone suppression first. But if your dog looks like this St. Bernard, and it doesn't have alopecia, and it doesn't have some of those other problems, but Cushing's is a differential because polyuria, polydipsia, a mild increase in alk phos. Do not do a low-dose dexamethasone suppression because it won't suppress and you'll think he's got Cushing's. It's a sick, stressed dog that's in ICU. ACTH stim because it got the lowest false positive. If it looks like a Cushingoid dog and you're very confident, no problem. Low-dose dexamethasone suppression. Now, one of these test results, I want to try to distinguish which one of these two is present, the adrenal tumor or the pituitary tumor. But first, do not take shortcuts. You got to rule in that the dog's Cushingioid before you start differentiating which one of those is present. So here's a case. It is a mixed bred dog, and it's got polydipsia and polyuria. Name 10 differential diagnoses, and your first one should be renal failure. At least I'd pick it first. And then Cushing's could be right up there. Now you even know how it could be Addison's. You know how it could be liver, psychogenic, polydipsia, secondary polyuria. Substances that interfere with the function of ADH, high calcium, steroids, pyometra. Look how easy it is to come up with 10 differentials for PU and PD. Stress leukogram, few nucleated red cells. What the heck's that say? 6,600. That's a productive enzyme. So the leakage enzymes are not quite as high. He must have diabetes mellitus. He's got 280. Bzzz. Steroids can raise the glucose. Low-dose dexamethasone. There's basal concentration. Here's the basal concentration, low-dose dexamethasone. And then 8 hours later, what's the concentration? And it should be less than 1. And it's 4. Diagnosis? Cushing's. Yeah, and it fits with all this. I do my ACTH stim. It should stop at around 20. If it goes over 22, diagnosis, Cushing's. Oh, I've got a high level of confidence this dog has Cushing's. Which one does it have? I don't know. But if I'm going to go to Las Vegas, which one should he have? In other words, pathology. What's the most common lesion that causes Cushing's? Pituitary dependent, a microadenoma in the pituitary. Path is medicine, and medicine is path and clin-path. You don't have to separate them along the way. So I have a really high level of confidence in this diagnosis. I'd like to now distinguish which one is present. Uh-oh. Approaching 3 o'clock, and the slide says the next one's a little complicated? That doesn't look real good. Huh. Oh, give me a break, Meuten. Okay, here's low-dose dexamethasone. AT means there's an adrenal tumor. And why do people like low-dose dexamethasone for adrenal tumor? Here's 85% of dogs with adrenal tumor don't even get close to the normal response. That's 85%. 15% of the dogs with the adrenal tumor don't suppress to that level. You got every adrenal tumor. Poof, piece of cake. If it's pituitary dependent, only 25% of them are high and stay high. 15% decrease somewhat, but they're still high. And then what the heck is this? This is basketball. Rebound. Low-dose dexamethasone, in about 25% of the cases, will rebound. Michigan should have known how to rebound. So it'll start high, it'll drop down, but at 8 hours, when you read the test, it's increased again. Got it? Every test I give you must be perfect, or I wouldn't tell you about it. What the heck is this down here? ClinPath isn't perfect. 5% of pituitary dependence will suppress, and you're fooled. Hey, that's not bad, folks. Do not expect 100% with anything, with your morphologic diagnoses or with ClinPath. See that rebound? You're going to see it again. That rebound means pituitary dependent Cushing's. So if it'll drop down and bounce back up, pituitary dependent Cushing's. I forgot, how big is the lesion in the pituitary? It's tiny. Therefore, with a low-dose dexamethasone suppression, you may be able to suppress it for a short time, and then it'll bounce back up. So the size of the lesion is helpful. And what's the problem? If you run this test on a bunch of sick, stressed dogs, 60% are false positives. Practicing veterinarians don't appreciate that, partly because they're smart and they're only using, or they're trying to use this test because there's other clinical signs and ClinPath lab data to suggest it's Cushing's. Then that's a good test to use. Here's the one I like if you're just going to screen. It's cheap. Urine, cortisol, creatinine ratio. It's a good estimate of what steroids have been being produced over the last 24 hours, and it's great because I don't have to touch anything. I'm going to tell the owners tomorrow morning, collect a urine sample. Actually, I wouldn't say that. Wait about 2 or 3 days before you collect the sample. So it's been in your office. You don't know what the dog's got. Cushing's is a differential. But when the lab data comes back and you see the high alk phos, inability to concentrate urine, and Cushing's goes up, that's a good time to run a urine cortisol creatinine ratio and just tell the owners to bring in the sample from the morning. Why the morning? That's the most peaceful time of the day. No stress. Not when the spouse came home and started yelling at the dog. So do it in the morning, a nice night's sleep. And look at how good this test is. 90% of dogs, let's do this one. 95% of dogs with Cushing's, it's increased. Huh, doesn't that sound great? 80% of dogs that don't have Cushing's, it's increased. Why? They're sick and stressed with whatever the disease is. But this is what I love about it. 90% of dogs in which those values are not increased don't have Cushing's. And you ruled it out with a test that the owner brought you the sample and for an economical price. It's just like low-dose dexamethasone. It's better to rule out the disease than to rule in the disease. Got it? I think that's a real practical use of that test. And then I love to show this one. Here's some ratios in different dogs. And I've got to read the chart that's over here as well. Yeah, here's a dog that just comes into a veterinary hospital, sees me, bloop. Here's a dog that comes into the veterinary hospital and you decide to keep it overnight. Whoa. Here's a dog that had an orthopedic procedure done. These dogs aren't stupid. They remember the vet hospital, and now look how long the increase stays. Increased urine creatinine cortisol ratios happen from stress. Stress could be the real disease, or stress could be other factors. But if it's not increased, oh my gosh, you get to rule it out, and you did it very economically. This is a very, very important principle. You don't have to remember the detail I'm about to show you, but this principle is really important. Here's urine cortisol creatinine ratio, just what I told you about. And here's a whole bunch of normal dogs. They're healthy. It's not increased. And here's dogs with Cushing's. 100% of them are increased. Well, that's the test to use. Here's dogs that don't have Cushing's, but they got polyuria, polydipsia, and they have some signs of Cushing's. Bzzz. Look at all the dogs that have increased values. I can rule out Cushing's in this group, and I can feel real good because of this. But I can't rule in Cushing's here because they are sick, stressed dogs. If a ClinPath test or an anatomic pathologist can't differentiate normal from diseased, we're worthless. Every test has to do that if you're going to use it. You got to differentiate it from normal. This is what you want Dr. Alves to do with the biopsy specimen. He can take diseases that look similar and tell you which one is present. That's what I need my ClinPath test to do. take animals with look-alike diseases, and my test differentiates. But if it can't differentiate, it's not as valuable. Got it? And most tests are not 100% pathognomonic by any means. But this is a great test to rule it out, and low-dose dexamethasone is a great test to rule it out. Just more word slides. Give me a break. Summary, where are we at? Great test to rule it out. If it's normal and ALK Phos is normal, rule out Cushing's. Cheap. That was in your biochemical profile file, and that was 20 or 40 bucks. If both of those are normal, rule it out, move on. If that's increased, and you're still suspicious it's present, yeah, now go do your low-dose Dexy. You already paid for the ALK Phos with the serum profile, and you spent a little bit of money with the urine cortisol. It's really a useful test because you can do it at home. If those values are present, an ALK Phos of 4,000, they can't concentrate the urine because steroids interfere with the action of ADH. There's bacteria in the urine. Whoa, that must be a typo. What's that say? No white cells? Wait a minute. Bacteria, no white cells? That's either contamination or Cushing's. Cushing's will interfere with the ability to produce inflammation, and you can have bacteriuria without white cells. Yeah. Or it could just be you let the sample sit around at room temperature too long. But if this is what my patient looks like, what's the first thing I'm going to do? Low-dose Dexy. It's classic. Now you want a different patient looks like that, got all the lab data, low-dose Dexy, failed to suppress. Now you want to decide which one it is. Is it a surgery candidate or is it a medicine candidate? And Dr. Cudd, if I don't want to do this because I can't remember how to do it, I could put the dog on trilostane. And then it doesn't. That's the theory of the trilostane use. It interferes with the synthesis of the steroids, and clinical pathologists are ruled out. It doesn't work as good as the manufacturer would say. Or at least that's what my pharmacologists tell me. All right, enough philosophy. How are you going to decide which one of the two is present? There must be another test. Treat and test. More than one way to castrate a cat. So it doesn't have to be just any one of those. So I'm going to do the easiest one first. It's probably the most expensive, but it's the easiest. Let's measure how much ACTH is coming out of the pituitary, just like it was in Addisonian. There's our reference range. If the pituitary is making too much ACTH, what should the concentration be? Yeah. Is it a perfect test? Nope. And there isn't a perfect test. But sky-high concentrations? Yeah. If it's an adrenal tumor making too much steroid, that's negative feedback to the corticotropes, and therefore what should endogenous ACTH be? Undetectable. 0. Is it a perfect test? No. And because of pathology, you can always explain this. There may not be 100% atrophy. Atrophy happens over time. It's not snap your fingers and it's absolute. These guys may be chronic cases. These could be early cases. It makes sense if you think of the lesions that are present. You cannot measure this first and shortcut the steps. You can't. If you decide to measure endogenous ACTH before you do a low-dose Dexy, look at the overlap that's present. You can't. You got to work your way through it in a logical fashion. Then it's a great test. So now you're going to do a high-dose dexamethasone suppression at 3 o'clock in the afternoon, and Meuten's been talking for 2 hours. The principle of this one is I'm going to give a dose of steroids that's so large, I will suppress that little tiny pituitary tumor. but I can't suppress the adrenal tumor because it's cancer, it's a loose cannon, it's not listening to any stimuli. In fact, we're going to give a high dose of glucocorticoids. What does this dog have in its circulation? A whole bunch of glucocorticoids from the tumor. I can't suppress it. But this one, the steroids are coming from the axis. And if I get my dose of steroids 10 times the low dose, I can break the axis. And then I should see a decrease in cortisol that I measure. That's the principle of it. You understand the lesion, then you can figure out what you're doing. You can't do this on a sick suppressed dog because it will suppress. You're going to override that principle. All right, to try to speed the process up that you'd go through for this deal, if it's got an adrenal tumor and it's a low-dose dexamethasone, remember, 100% of the ATs did not suppress. The pituitary-dependent, 95% did not suppress, and this is measuring at 8 hours. If you wanted to, you can go back early and look for rebound. Low-dose Dexy, and you have the lab data that says Cushing's, and you see that rebound phenomena, that's good enough to call it pituitary dependent. Plus, this is 80 to 90% of the cases. So that part fits with the diagnosis. And then it makes sense. I showed you some pictures of imaging, and they can even image the pituitary. Or you could start treatment. Dr. Cudd, trilostane. Decreases synthesis. These others actually would destroy, or supposedly selectively destroy, zona vesiculata. Smart writer? Not so smart writer. Gelding? Gelding. Stallion. Any questions with Addison's or Cushing's? South America, any questions with Addison's or Cushing's? Representing the country, the continent of South America, Dr. Alves.
A quick question. It's for Theo. Do you see any, or typically see EMH with pheochromocytomas?
Dr. Alves asked, do I see EMH with pheochromocytomas? And my answer to that, Tony, is no. I should expand. I've never tabulated both to be certain, but I haven't seen it with it. So I favor it for the corticals. Have you seen it in some?
Well, we've had some, is it a medullary tumor or is it a cortical tumor?
Yeah.
And there's EMH present.
Yep.
So then nothing's absolute, right? So, but if you've seen them with the pheos with EMH, then maybe they'll sway us and say you can see them with both. But if
Bingo. I haven't seen it. So now I'm going to ask Dr. Alves a question. Am I old or young? I'm old enough, Tony, that I wasn't using IHC to confirm. And in some of those, it can be difficult to differentiate which one is present. But this day and age, with IHC tests that are available, you should always be able to differentiate. So if anyone sees a fail, and you've got data to say this really is a fail, yeah, and you see EMH, oh, please share it with me. Because as you said, I still like to learn. I'm approaching the hill, but I'm not over it. So if I can still learn, it'll be great. Cats, 100% have a pituitary tumor. Cats don't respond to lysodrin in the adrenal gland anyways. Essentially, 100% of the cats that have Cushing's disease have concurrent diabetes mellitus. No, I did not say 100% of cats with diabetes mellitus have Cushing's. It's the opposite. So 100%, or essentially 100% of the cats that have Cushing's will have diabetes mellitus because steroids are an insulin antagonist. Because diabetes mellitus is common in cats, and you get to have overlap of the diseases. But in cats, it's always this macroadenomas. So the screening test and the differentiating test, you don't have to worry about as much in cats. It's going to be an adrenalectomy that'll be performed to treat those. 100% of horses. This is one of my famous endurance horses. No, not at all. But he's sway back. That's supposed to be long hair coat, hypertrichosis, maybe sweating that goes with it. And they've got a tumor of the pars intermedia, essentially 100% of them. How good is ClinPath to recognize this disease? If the horse looks like that, and it's got a tumor in the pars intermedia that looks like that, you've got these pieces of clinical evidence that go along with it. Oh my gosh, my lab data is perfect. But you don't need my lab data if you've got all that clinical patterns that are also present. ClinPath is useful when you're not sure what disease is present and it's going to rule in or rule out. ClinPath to recognize these mild lesions inside pars intermedia, if the disease is early, is no good. I say that just to keep it simple. We can do dexamethasone suppression test. We can look at melanin stimulating hormones, MSH, and none of them help in the early diagnosis of Cushing's, definitively. They're great when it's a fully developed case, and then you don't need it. This is the slide that I need to go into long details at 3 o'clock in the afternoon to explain these intermediate substances that are produced by the pars intermedia tumor. Everyone that would like me to provide these interesting details, raise your hand. I thank you. No, don't you dare. It's an interesting story, but it's unique to the horse, at least as far as I know. But they make these intermediate substances, clip and so forth, and some of these you can measure to help the interpretation, but it's a difficult story to keep simple. This is a fun disease, equine metabolic syndrome. That's a name, and that's a name for couch potato horses. They've given it a name. It's a fat horse. It's under-exercised. It's overfed. And what do the owners want you to diagnose? An endocrinopathy. And if you test for hypothyroidism, it'll, quote, test positive. Why? Euthyroid syndrome. These horses are obese. They're under-exercised. They are essentially a type 2 diabetes mellitus. And even some of these hormones that we associate with type 2 diabetes in people are produced by the fat cells in horses. So I do think this is an interesting and fun name to give the owners. In fact, it's an insulin resistance that's developed because of the fat cells from too much food and not enough exercise producing recitin. I don't know if they know that for the dog stories, but it's interesting that they know that for the horses. Pheochromocytomas. So I see extramedullary hematopoiesis all the time with these. I'll use that feature that Dr. Alves brought out to help me differentiate it. They should have that classical microvasculature, neuroendocrine packaging of the cells, and it's an epinephrine, norepinephrine product that they're producing. So in the adrenal medulla, you like to think of them being white, pink, because of all those tiny little blood vessels that are present. And you might have some hemorrhage that's associated with it. But that's the lipid that you associate with the cortex, and these are the tyrosine amines that you associate with the adrenal medullary tumors. Different color. 50-50, I don't know what percent, Dr. Alves, or malignant versus benign. There's the Met. I do favor, once they grow into that vena cava, I'm going to pick pheochromocytoma, but adrenocortical tumors will do that too when you finally get one that's really aggressive. And you always have this Zankers type product that you can add at gross. So yellow, I don't know what color you're going to pick. Maroon's an exaggeration. Brown, and then here's the white or the hemorrhage that's associated with the tumor. And then this is the discoloration that you get with a Zankers solution if you apply it to one of those pheochromocytomas. You got that photo, Dr. Williams?
No, but I got the other one.
Oh, you do? Yeah.
I showed that once. And, Dr. King gave me a raspberry when I explained how the field was white. And,
he didn't like that?
no, I said,
well, if Dr. King says that, I always need to stand down. But I kind of use it. Guernsey bulls. Guernsey bulls, familial, multiple endocrine, neoplasia. I can never memorize who's type 1, type 2, 2A, 2B. So you just have multiple endocrine tumors, thyroid, C-cell, pituitary, and then a pheochromocytoma. And then others might have a parathyroid tumor. It's the entities that go with it. You can now explain each one of these. And that's what I brought for the adrenal gland. I do have a daughter. She's a dentist. That's Fat Cat. Bruce. There's Dr. King. Yeah. He gave Bruce one, me one. Big dog. Rat. That's Danny DeVito. Little Corgi Cross. And that's my favorite dog. That's Poppy. Oh, yeah. Now we're going to do positive and negative predictive values of every test that you've ever heard. That's it. Yeah, at least I'd stop it there. Bruce knows me. Of course, I have other stuff, but
let's leave him wanting more.
Yeah. Isn't that a fun photo?
Okay.
But that's essentially what we just went through. Good?
Good.
I mean, if you wanted, I brought thyroid and parathyroid, but, you know, he gets saturated.
Especially free. Say good night, Gracie.
Say good night, Gracie. It's been a great show. They may not appreciate